I would like to call upon my friend Mark Eidelman from Haifa, Israel. Mark is a dear friend and he's really stayed in touch. He comes to a lot of the meetings all across the world. So Mark, please take it away.
Thank you, Sanjay. I hope you can see my screen.
Yeah, just do this.
Thank you again, Sanjay, for inviting me. It's a real honor to be here with my dear friends, Scott, Fergal, and Orgro.
Mark, can you do the slide share? Yeah, slideshow rather. Yeah, there you go. Thanks.
Just a moment. Okay. Is it okay?
Yes, thank you. Yeah.
So I will talk about the Israel perspective. Here's my disclosures. Israel is just a moment. I have a problem. Just a moment. How is now? I don't know why it's not.
See the slide deck on the left. Yeah, I don't know why your right bottom, which you're trying to click, the slideshow, is that not working? Slideshow.
I tried, but that's how it appears.
We can see it. Just make it the screen bigger.
Okay.
That's fine.
Okay. Israel is a tiny country with plus minus 20 public hospitals, many private. Majority of children in Israel receive care in public systems. No. So, this is by the way. Okay, this is by the way my city, Haifa, in the north of the country. So we are nearly 9 million. Israel is a tiny country with approximately 20 public hospitals, many private, and majority of children receiving care in the public system. This is my city. We are 9 million people, plus minus 50 pediatric orthopedic surgeons, and 6 hospitals have fellowship trained deformity surgeons. There are not many congenital cases in Israel because uniform screening for all pregnant women. Majority of congenital deformities in Israel in Orthodox Jews and Muslim Arabs because of religious principles. So here is my hospital place where I'm working. This is the Faculty of Medicine. 2 Nobel Prize winners came from this place. And this is my hospital, Ruth Children's Hospital of Haifa, which is part of Rambam Healthcare Campus. So my way to be deformity surgeons, I was 5 years chest surgeon in a former Soviet Union in Uzbekistan. And I did the residency from 1994 to 2000. It was a difficult time in Israel with the Intifada and terroristic attack and all what you can imagine. I did residency in tertiary trauma hospital, and I dreamed to be trauma surgeons. Did hundreds external fix for combat trauma in soldiers and civilians. Never dreamed to be pediatric orthopedic surgeons. In 2001, our unit had 1.5 attending surgeons, 48 operations per year. So in 2001, I start with the slide that you lost me. My unit was 1.5 attending surgeon, 48 operated in 2000, or in once in 2 weeks, and cast for most fractures. There was no deformity correction, no bone lengthening, a pretty boring situation. In 2001, I was in IPOS. I met Dror and John Erzenberg. I saw for the first time Clubfoot Ponseti, and I met 2 lifelong mentors. It's more than 20 years. We have continuous friendship and mentorship for so many years. And after 20 years in 2002, we have 1820 OR per month, 6 attending plus Fero, nearly a 900 operation, at least one deformity case per week. What can I say? I can't imagine my life without another mentor, Scott Nelson. Just today, I did a Langenskjöld, Scott, what I learned from you. And Scott operated with me at least once in a year, as well as John and Dror. So this is my team. And you remember we start with 1.5 sergeants. Now we are 6 plus fellow, and it's my continuous pride. If anything achieved in my life, it's my team. I choose all of them from residency, and most of them will be much better than I. So what we are doing in Israel, others don't do it. Just now in Nashville, Sanjay invited me for the session. There was a treatment of a congenital anterolateral bowing, and it was a discussion between Dror and Mark Dahl between hepiphysiodesis and cross union. I think that McFarland, it's forgotten procedure, and it should be mentioned. Many of you never did it. Some of them never heard. And it's like a support for Pisa Tower. I learned it from John Herzenberg. We did altogether 4 cases. There is no consensus in the literature what to do with congenital anterolateral bow, which is precursor of CPT. And the standard treatment is just bracing and observation because surgeons concerned to create iatrogenic pseudoarthrosis. Remember that CALPT is a combination of valgus recurvatum proximal fragment and varus procurvatum of distal fragment. So what a surgical option for CALPS? Hemophysiodesis, cross union, and in my opinion, it also prophylactic bypass by McFarland. So some short review. In 2017, there was only 1 case report about medial proximal distal tibial hemophysiodesis. This is the best case. And if you see there is thin tibia still after 4 years, Mark Dahl from Minnesota published 10 patients and no fractures with distal lateral hemophysiodesis, 6 required reoperations. And if you're looking, it's much, much better, but I'm not sure that it will not be fractures. And Dahl conclude very fair that even if this technique only delays fracture, this is still of great benefit in improving long-term prognosis and function. So there is a Brian McFarland published in British GBGS in 39 and 59 patients. This is not actually anterolateral bowing. This is the pseudoarthrosis, and you see the final results. This is Pele type 4, actually. 10 patients were described run by a group from Philadelphia. If you're looking on this, I think it's actually, should be much closer to growth plate, okay? But the result after 10 years, you can see it's still a deformity, but there was no fracture in 10 patients. We had with John 4 patients, mean follow-up 10 years, and most patients had Pele type 1 fracture of the fibula. So what is the technique? We applied Hemaclear, a posteromedial bypass. It's not percutaneous procedure. Look at this. This is the exposure of the tibia. Now you're doing the notch proximally and distally, and put the graft inside of the notch, temporarily fix it by 2 K-wires. So to fill the space between graft and tibia, only with autograft is unrealistic approach. So I put the autograft only at the corners and fill all this space with allograft. So As I said, it's not percutaneous procedure. In all my cases, I did the percutaneous anterior fasciotomy. And here's the example. You see the anterolateral bowing, immediate, and this is after 6 months. And if you're looking on this patient don't need any of our patients use the orthosis after this. It's impossible to break this support. So this is the first case of John. He did it in Afula Hospital with no on board. It's belly 2A. And you see this is after immediate x-rays. This is 4 months later. This is 1 year later. This is 2 years later, 6 years later, 10 years later. And no braces, normal life, excellent alignment. So this is another case that started with John at age 3. He operated it in Israel, a pretty severe deformity. 6 years later, he came to me 10 years after, and you see pretty severe deformity, no fracture, but it's a really severe deformity. And I did the 2-level correction of the proximal tibia. Look at the final alignment. This was my first case, and I did it incorrectly. I put the graft not close to the growth plate. Nevertheless, it's united, never broke. I put emphysiodesis proximal and distal. It gives me opportunity to correct at the maturity with single osteotomy, and you can see the correction with a hexapod. And here's the final alignment with a little bit cross union. So this is by the way, 10 years follow-up. In conclusion, it's for Pele type 1 2A, prevent fractures, a relatively simple procedure. It doesn't burn any bridges, and malalignment might be corrected safely close to maturity if needed, and it's really, really doable. Regarding global care, I operated nearly in all former Soviet Union Republic. I operated with Scott in Port-au-Prince, with Norcroft in Uganda, in Ethiopia, with John in Ecuador. And it's a really, really, really joy to be pediatric orthopedic surgeon. Thank you very much for your attention. I apologize for the internet loss.